The InterLymph consortium was set up to understand what causes lymphoma, and we did lots of case control studies, but we also realized we could take the cases and follow them up to understand predictors of survival and long-term survivorship. The areas we've been working in have been two broad areas. One is the role of host genetics, that is the genes that you inherit from your parents. Does that have a role in your survival and long-term, either from your cancer or your overall long-term survival? And then the other big area we've been looking at is the role of lifestyle factors, asking questions like, does physical activity, alcohol use, smoking impact your outcome once you have a lymphoma? We're still pretty early in this. Some of the early findings are that it does appear that some genes are involved in predicting your survival. Some of these overlap genes that increase your risk, but many of them don't, and we're just really starting to understand that now. That may give us some clues also into new thoughts on the underlying biology that might lead to new treatment approaches as well by understanding the host genetics. We're also just starting to learn some new things about lifestyle factors. Some early data suggests that smoking and overweight not only impact your risk of getting lymphoma, but also impact your outcome, where things like physical activity might be protective. So we're looking at a bit more of that. One of the areas that we've learned a lot in the last couple of years that are very relevant to patients is so we started studying, when we started studying survival, we found that patients with one of the most common subtypes, follicular lymphoma, diffuse large B-cell lymphoma, but this also applies to follicular lymphoma, that if they survive 24 months without having any relapse, they actually go back to the background population risk. So more or less, it's not exactly cure, but it's pretty close to cure. That is, if you're diagnosed, you're treated, and at 24 months you've not had a relapse, then you're at sort of no different risk than the background population. This has a lot of implications for patients. One is now you need to be worried, not worried, but you need to be thinking about other causes of death. So you need to take care of your heart. You need to get your other screening, like colorectal cancer screening. For women, they need to get mammography. It's had some clinical impact. After we observed that result in diffuse large B-cell lymphoma, we went back and looked at how was it really valuable to get CT scans after 24 months, and found that it wasn't, because there are very few relapses. There are some, but they're very small numbers, and that's actually led to practice change, where it's no longer recommended to get CT scans after 24 months. And the third area that's really impacted for patients is, at least for diffuse large B-cell lymphoma and probably the more aggressive follicular lymphomas, the people that are having early relapses are really a clinically unmet need, and we're really focusing a lot of our attention to understand that biology, i.e., can we identify those patients up front? What's the characteristics of those tumors? Do they need different kinds of or new therapies? So for example, for the people that go 24 months without it, the current therapies are great, but for those that don't make it, and we like to find those up front, we probably need to find new therapies.